And good morning, ladies and gentlemen. I am Feng, and it's my great honor to present at the ICCS webinar. The topic is the quality assurance in feed screen program. Why do we do quality assurance? I think there are two main goals. And the first is the prevent incidence colorectal cancer, which is interval cancer, and the relative mortality. Second, improve the effectiveness of the entire screening process. This is the workflow of Taiwan colorectal cancer screening program. There are three most important aspects of quality control. First, the adherence to screen program. Second is the quality of feed. Third is the colonoscopy quality. The first part is the adherence to colorectal cancer screening program. As you can see in the bar chart, the data was Kaiser screening cohort from 2002 to 2012. The majority of deaths from colorectal cancer are the patients who never screened or who do not screen regularly. The situation was similar in Taiwan. We can see that, we can see that the pie chart, the colorectal cancer from the patient who never participated within screening program attribute for 40% of colorectal cancer. The survival status of these cancers was worse than screen detected cancer or interval cancer. So the colorectal cancer from non-participants largely decreased the effectiveness of screening program. The screening program organizer should establish the free of charge screening program funded by national or regional government, and the insurance should cover the screening and the assessment test to optimize the adherence to screening program. Let's move on to quality assurance of feed. Within Taiwan screening program, the laboratory who are given accreditation of feed have to meet three conditions. First is the laboratory should use quantitative test equipment. Second, certificate of proficiency testing from Taiwan Society of Laboratory Medicine. Third, the laboratory should get the CAP or TAF certification. Otherwise, there are two brands of feed used in Taiwan screening program. One is OC sensor and the other is HM jack. However, the HM sensor seems to have higher cancer detection rate. For the interval cancer rate, the OC sensor has significantly lower interval cancer rate by 25% than HM jack. So for the quality assurance of organized feed screening program, we should use single feed with better performance. In addition, the ambient temperature is also an important issue for feed. From Charles' study, they found that the performance of the feed was influenced by seasonal variance in Korea. The feed interval cancer rate was higher in summer and autumn when the temperature was higher. In many areas of Asian countries, the average temperature are higher than 30 degrees Celsius. And because of the climate change, the global temperature continues to significantly warm. So the screen organizer should establish the quick return system of feed processing. This is some commendation about feed of Taiwan colorectal cancer screen guideline. In the guideline, feed stool samples should be refrigerated and submitted within 7 days. The next part is the quality assurance in colonoscopy. Timely referral for colonoscopy is crucial. From the data of Taiwan screen program, if the FIT positive subject didn't undergo confirmatory colonoscopy, they had more than 64% risk of colorectal cancer mortality. If the time to colonoscopy was delayed more than 6 months, the risk of developing advanced colorectal cancer was more than twofold. There are two key quality indicators of colonoscopy. One is the second intubation rate, CIR, which is associated with the incidence of PCCRC. The lower CIR, the higher the risk of PCCRC. The other indicator is the adenoma detection rate, ADR. The ADR is associated with the incidence and the mortality of PCCRC. From the Kaminsky study, they found that improvement in ADR was associated with declined PCCRC, compared with no increase in ADR. Reaching or maintaining the higher ADR category decreases the risk of interval colorectal cancer. The level of bowel preparation is also important. Improving bowel preparation leads to enhanced detection of proximal and non-polypoid lesions. This figure is the framework of colonoscopy quality assurance system in Taiwan. All colonoscopy data was collected in central database. The hospital level and endoscopy level of CIR, ADR, and the bowel cleansing level will be calculated. Then this result will be feedback to each hospitals and the endoscopy unit. In the Taiwan screen program, for the FIT positive confirmatory colonoscopy, all hospital and endoscopy unit use the standardized electronic colonoscopy report format to facilitate, calculate data collection and the evaluation of colonoscopy quality. The government also holds a meeting of site inspection for hospital with low ADR. By the site inspection, the government could find the reason of the poor ADR and help this hospital to improve the quality of colonoscopy. As we can see from the figure, the yellow dots was the ADR and the CIR of each hospital in Taiwan between 2004 to 2009. The blue dots was during the ruling out period between 2010 to 2014. We found that the colonoscopy quality was improved. During the rolling out period of the most hospital, their CIR were higher than 95% and the ADR were higher than 40%. Of these hospitals, the incidence of PCCRC was lowest. As a result of improving quality of colonoscopy, the incidence of PCCRC decreased since 2010. Another quality indicator of colonoscopy is the colonoscopy-related complication. Because the FIT positive subjects are associated with the increased risk of adenoma, large adenoma, and the synchronous adenoma. So the complication risk was higher than ordinary colonoscopy. The complication rate in FIT positive colonoscopy was 7.6 per thousand, and the rate of severe bleeding was 6.7 per thousand. FIT colonoscopy was associated with more than 3-4 risk of significant bleeding. So some new colonoscopy technique as cold snare polypectomy, which decreases the risk of bleeding, should be used for the FIT positive confirmatory colonoscopy. In conclusion, constructing an audit system is the most important. Adherence to screen has a big impact. and the different brands of quantitative fit perform differently. Improvement in ADR and CIR could reduce PCCRC. Fit colonoscopy is associated with a higher risk of complication. Thank you for your attention.